Okay, so one momento. Yep, so moving on with endocrinology. Yes, just let me 1 second. I need to get my phone. Riyadh. Let me start the recording, and here we go. So, this is a glycogen and this is a glucose. So basically glycogen is a plenty of glucoses. The next concept I want you to know, what does it mean, glycogenolysis? Well, it's the destruction of multiple, this thing, which is multiple sugar, the polysaccharide, into many monosaccharide, yeah? Not connected to each other. For example, a monosaccharide example, typical example is glucose. Okay. The next thing, what is a glyconeogenesis? Glyconeogenesis is a process that occurs in two organs in our body. The kidney and which other organ? The liver. Yep. So this process is basically taking substrate which are not sugar, and it helps us to make sugar out of them. Okay? So when we are speaking about this procedure, we cannot forget about this. Let's consider that this is one of our cells, and we have a glucose here. How can I take the glucose from here and put it inside of the cell? What do I need to do that? Which hormone do I require to take glucose from out of the cell and put it inside of the cell? So the hormone needed is obviously insulin. Yep, it's insulin. Okay, so when the insulin works and he gets the glucose inside of the cell, what is going to happen to the level of the glucose in the blood? Drop. Absolutely, it goes down. So the glucose level is going down. Okay, there is another hormone called the glucagon. It has the exact opposite function. So now we can speak a little bit about insulin. First of all, where it is produced. It's produced in the beta cells of the pancreas. Yep. So, and it's produced in an inactive form called preproinsulin. Preproinsulin is just like, if you remember guys, the process of translation, we said we have the mRNA that becomes a protein. So the most initial protein that comes out, we call it a preproinsulin. That preproinsulin is going to get modified and somehow to become a proinsulin and then to become actual insulin. We call all of these post-translational modification. Post-translational modification. So preproinsulin is synthesized inside of the rough endoplasmatic reticulum. Does anybody remember why the rough endoplasmatic reticulum rough? Ribosomes, absolutely, yes. Of the pancreatic beta cells. So cleavage of the pre signal, it creates the proinsulin, which basically remove the pre, which is the preproinsulin. It kicks out the pre, so we have a proinsulin, which is stored in secretory granules. And this proinsulin, it's going to basically is ready inside of the cell for the release. Well, release it from where? From the beta cell. And next comes the next step, which is the most important one, the cleavage. So you have this thing, the proinsulin. Notice, insulin is this thing. Just like somebody asks you what is insulin, tell him it's a two chain that have some sulfur bound between them, disulfur bound between them. Yep, that once I actually was asked about this in real life, so it's a good party trick. It's never asked in the USMLE though, but for the sake of completeness, the insulin is a two chains of polypeptide, which makes it a peptide like a protein, and they have a disulfur bound between them. Okay. So cleavage of the pro-insulin lead to exocytosis of the insulin and the C-peptide equally. Is this important? Super important. So yeah, when it gets out from your pancreas, this is going to be cleaved. This first particle is going to be released into the circulation, and this as well, but they will be cleaved from each other. Does that mean any person who have like insulin secretion, he will have an increased level of C-peptide? Yes, that is true. So if that is the case, is that going to help us clinically? Does it have any meaning? Can we measure the C-peptide to check how much insulin is released? Yep, absolutely. Okay, I will tell you now the clinical significance of this. Some people inject insulin to themselves. Why would they do that? Healthy people do not have diabetes, but they inject insulin to themselves. Why do you think so? Well, psychiatry is the reason. People who inject insulin to themselves can be divided into one of two peoples. The first type of people, we call them malingering. Malingering people are people trying to get an external gain. What does external gain mean? For example, I inject myself to insulin not to go to work for today and get some money for it, for example, for not going or something. Or I inject myself with insulin. This is malingering. And the other one is fastidious. Fastidious disorder, it goes something like this. I inject myself with insulin not because of external gain. I'm not about money. I want people empathy with me, okay? I want people to say, oh, poor man, he injected himself with insulin, okay? Oh, sorry. Oh, poor man, he has hypoglycemia, because secretly I will not tell anybody that I injected myself with insulin. This we call fastidious disorder. So we have fastidious and malingering. Malingering, external gain, money. Fastidious is internal gain. Well, what is it? Empathy. Okay? So this will be our topic for psychiatry. Anyhow, I want you to know that people inject themselves with insulin. The insulin that we make inside of the factories, the manufactured type of insulin, does it have C-peptide in it? Any idea? It does not. C-peptide does not have an actual function. So it's nothing. It's just like a byproduct. Actually, that's why we cleaved it. So the actual insulin produced by the factories does not have C-peptide in it. That's a good thing. Why? If your patient is coming to you and he has hypoglycemia, you check his insulin level and you find it to be really high. And then you are like, suspicious, insulin is really high. You check the C-peptide and it's super low. And you tell him, did you inject yourself with anything? And he'll tell you, no, doctor, I will never do such thing. But he has hypoglycemia, high insulin level, and low C-peptide. What do you think he has? Does he have an insulinoma, a tumor that hypersecrete insulin? Or is he lying to you and he's taking the drug? Case 1 or case 2? He's lying. Yep, he's lying. Case 2, absolutely. So this is a way to differentiate if he's lying or not. And why differentiating that helps? Because this literally can save his life. Guys, regarding hypoglycemia, if you have somebody with hypoglycemia, what do you need to give him, logically? Like somebody come to you in the emergency department and you suspect hypoglycemia. Why? He's a diabetic patient and he comes to you, he's in a state of like fogginess, confused. You give him glucose. Okay, so we gave him a glucose. Okay, so should you check the blood glucose first or give him the glucose first? I mean, maybe he has hyperglycemia. Diabetic patient have hyperglycemia. So if he has hyperglycemia, will you give? That's the tricky question. You don't check. Why? Whatever the cause, give a glucose. That's the rhythm of it. Just like memorize it like this. Whatever the cause, give a glucose. Why this is important? If he had hypoglycemia, well, perfect. He get normal glycemia. If he has hyperglycemia and you give him glucose, what he will have? Hyperglycemia. He already have that. Hyperglycemia, if it will kill you, it will take you multiple weeks to kill you. Hypoglycemia can kill you in minutes. So because hypoglycemia can kill you in minutes, whatever the cause, give a glucose. Okay? So cleavage of the pro-insulin and then exocytosis of insulin and the C-peptide equally. Insulin and C-peptide are increased in case of insulinoma and also sulfonylurea use. This is a drug. I will be explaining its mechanism of action today. Okay. Whereas exogenous insulin lack the C-peptide, which makes you detect a patient who lies. What is the function of insulin? Insulin is a growth factor. You're like, what? No, it's not a growth factor. It's a hormone. I know that it's a hormone. But according to the classification, it's considered also to be a growth factor. And if you don't believe me, open Cellular Biology, page 1. Go under the second topic there. It's written that it's a growth factor. So insulin binds to the insulin receptor, tyrosine kinase activity, and that leads to glucose uptake, okay? A carrier-mediated transporter type of thing. So let's take a look about how this even happens. Well, how this even happens is a process. Basically, the insulin binds to the insulin receptor, which is a tyrosine kinase type of receptor. A kinase, what is the function of kinase, guys? What is the function of kinase? Come on. What is the function of kinase? Phosphorylate. Absolutely. It puts a phosphate. Yes, that's the main function of kinase. So, okay, now it's phosphorylating a couple of pathways. You don't have to know details, but basically there is a couple of pathways. This pathway, the phosphoinositide kinase pathway, or the RAS-MAP kinase pathway. The RAS-MAP kinase pathway, which I'm going to start with, it's going to lead to cellular growth and DNA synthesis, which is true. Like some people who eat something, like the moment I ate a big meal, which hormone is going to be released? The answer is obviously after a meal. What do you think? Which hormone will be released after a big meal? Yeah, that's true. CCK, all of that. But I want something that after I ate the meal, there is plenty of glucose in my circulation. So I need to get rid of this glucose from my circulation. So obviously it's going to be insulin, okay? Insulin. So if insulin is released, this process is happening. One of them, well, I ate a big meal. That will help me to become bigger. More DNA synthesis and cell growth. Yep. So the other pathway is going to help make a glycogen. What is a glycogen? What did I tell you about the glycogen? Polysaccharide, absolutely. So it's a polysaccharide, which is like multiple sugars. And this multiple sugars is a storage fashion. How much glycogen do we have in our body, approximately, an idea? And how long it can last us, maybe if you know. We have around 70 grams of glycogen in our body, and it can last us up to 1 day or 1.5 day max. It cannot last us more than that. For the lipid, also we make lipid after the big meal, protein synthesis as well. Okay, the most important thing, and basically all of this is just general stuff, non-relevant, but this is the most important thing. If we speak about the tyrosine phosphorylation, it's going to work on this pathway, which apparently going to get a vesicle that has these little channels, which are known as the GLUT4, okay? These GLUT4 are going to move, and they are going to move to the cell wall. And when they move to the cell wall, they will allow the glucose to move from the blood to the cell, which is going to reduce the amount of glucose inside of the circulation. So they write, it binds insulin receptor, the insulin tyrosine kinase activity, inducing glucose uptake, which is a carrier mediated transporter using the GLUT4, yes, into insulin dependent tissue, and also gene transcription. Wait a second. Gene transcription, we got it, like there was some making of some stuff here, like the vesicles and the lipid and the glycogen, even the cell growth and the DNA. But there is something fishy here. Insulin dependent tissue. Is there any tissue in our body that is not dependent on insulin? The answer is yes. There is many. Which tissue are independent from insulin? These tissues. The most important ones to know about are the brain and the RBCs and the spermatozoa. I will explain why when I reach them. So, anabolic effect of glucose include increase the glucose transport into the skeletal muscle and adipose tissue, which help you keep going basically. It increases glycogen synthesis and storage to use it in time of need. And which organs do the glycogen is stored at? Where do we store the glycogen? Where do you think, guys? In the liver, that's one. Also, it can be stored in the muscle a little bit and in the kidney, okay? We don't have so much of it, guys. We don't have so much of it. Keep that in mind. Just 70 grams. Enough for 1-2 days maximum. So, also, it helped make us triglyceride for happy times. Yep. And more sodium retention in the kidney. This is actually an important thing. I will tell you why when we speak about like cases of people like in psychiatry. Actually, it's funny because we'll speak about this concept in psychiatry. People who inject themselves with a lot of insulin are going to become hyperosmolar because of increased sodium retention. Also, protein synthesis in the muscles increase cellular uptake of potassium and amino acid. Oh yeah, that's actually an interesting prescription. If you work as in the pharmacy one day, just for an extra cash or something, you will find a prescription that says, give this patient glucose with insulin. Why would you give glucose with insulin at the same time? Probably you will think this doctor is crazy, because what is the point? If you give the glucose, it's not fitting. Absolutely. So here is the thing. If you have potassium really, really high outside of the cell, and you give the patient insulin, potassium, with the help of insulin, it's going to get inside of the cell. So what happens to the level of potassium outside of the cell? Decreases. Absolutely, it decreases. So since it decreases, so this guy will decrease. Okay, and what else will decrease with the help of insulin? Glucose. Yes, to prevent the hypoglycemia, you must give a glucose. Thus, we must give a glucose with insulin in case of hyperkalemia. Also, it decreases the glucagon release because I told you they work oppositely to each other, and decreases the lipolysis in the adipose tissue. Unlike glucose, insulin does not cross the placenta, which is a serious thing. Why? Because of diabetic mommy. A diabetic mother has so much glucose, and her child inside of her is going to have a lot of glucose in his system persistently, correct? So the mother is not producing she produces insulin for herself, but she's not passing it to her child. So her child will be the one who's going to suffer from it. What do you think will happen to the pancreas of the baby? the pancreas of the baby. Yes, it's going to become much hyperactive, okay? So if it becomes hyperactive, the pancreas of the baby, we call it hyperplasia and hypertrophy of the pancreas, right? So this pancreas is overactive. What is the big problem? I mean, there is a lot of sugar coming to him from the placenta, yeah? So he will be kind of in equilibrium with it, so he's too used with the hyperglycemia. But the problem will happen the moment he is born. Why? Because who used to give him so much glucose? Mama. Mama is gone. So what he will have now? Hypoglycemia, obviously, because his pancreas is overactive and there is no glucose. So he gets hypoglycemic. Can hypoglycemia kill the patient? Yep, it can. So the next thing we write here is insulin-dependent glucose transporter, the GLUT4, which we said. It's located at the adipose tissue and the muscles. So during exercise, we will have more GLUT4 expression, which is important for the uptake of glucose. Okay? Okay, the next one. Insulin-independent transporter. So some transporter don't really care about insulin. They work in a different fashion. For example, the RBCs, the brain, the cornea, the placenta, most important is the RBCs and the brain, okay? So these tissues do intake only glucose without the help with insulin. Why? Because these tissues are important and you will not be waiting for the insulin to be around. Insulin is not always there. It's secreted in a pulsatile fashion, which means you will not wait for your insulin to be there to help get the glucose into your brain. Guys, except of a glucose, what else can your brain eat? Itself, no. Ketones body, okay? So people who do keto diet, guys, in the beginning you will be drowsy because your brain is not used to the ketones body, but eventually he will be able to handle it. Is keto diet a good idea? Somebody said yes. Somebody said no. The correct answer, it depends. It's a time type of thing. So if you are doing it for 1 month, it's okay, no problem. But if you are going to do it for 3 months, check your creatinine, because it's going to lead to some dysfunction in the kidney. High level of ketones inside of the body is no fun for your kidney, okay? So if it's 1 month, no problem. Actually, most doctor advice right now, if you want to do keto diet, no problem. Do it for 40 days, take a break for 40 days, do it for 40 days. Because after all, your brain needs the glucose, and after all, your kidney don't like ketones body. They don't, okay? If you are in keto diet, can you drink alcohol? You cannot, because the alcohol can be converted indirectly into glucose, okay? Well, monosaccharide. So insulin independent transporter, RBCs, brain, cornea, and the placenta. And the GLUT2, it goes 2 ways. It has beta islet cell. It exists there. It's bidirectional. What does that mean? Well, it can move the substances as follows. Actually, I need to find a picture of that. 1 second. I think it's here. Yep. Okay. So, how can your pancreas know that he must secrete insulin right now? How does he know that, okay, well, now we have hyperglycemia and we need to deal with it? Well, basically, it also depends on this step. There is something called the GLUT2. The GLUT2 takes the glucose and put it inside which cell? The beta cell of the pancreas itself. When there is a glucose inside of the cell, you will have the process of glycolysis occurring, which, if you remember, it increases the amount of ATP inside of your cell. It doesn't matter which cell. Glycolysis always increases the ATP. So the ATP now is going to work at the ATP sensitive potassium channel, and that is going to lead to what? It's going to lead to closure, and that is going to lead to depolarization. So let's do depolarization. How to do depolarization? Well, let's take a look. It's steps. So they come and they close the target channel, and after that you will have a depolarization of the cell, and there is something called the calcium channels. It's a voltage gated calcium channels. Because you blocked this one, I'm blocking this one, the number of potassium inside of the cell is going up. So the voltage inside of the cell is going up. So now we will have the voltage gated calcium channels opening as well. When the voltage gated calcium channel is open, the amount of calcium is given to go more up. So full depolarization. Yes? So when the full depolarization happens, this is going to stimulate the vesicles to move into the wall and basically degranulate. When they degranulate, they release the insulin out. Don't worry if you did not get this. After I finish this, I will repeat the whole thing. GLUT2. So the GLUT2 is located at the beta cells, liver, kidney, and GI. Okay guys, let's take just 9 minutes break and I will see you in 9 minutes. So, yes, so speaking about the brain. The brain has two types of gluts, GLUT1 and GLUT3. So the GLUT3 is also located at the brain and the placenta. Back in the time, it was really high yield to memorize each glut and what it gives. But right now, this is totally not high yield anymore. It just like become, oh, okay. So yeah, it becomes something like not important anymore. A few of them are still important, like the RBCs, the brain, the beta cell of the pancreas, the spermatozoa. These are important. Okay. So the next thing we have is GLUT3 can be the brain and the placenta, GLUT5, 5 for fructose, F fructose, and F for spermatozoa, if you know what I mean, and F for the GI. Okay? So SGLT1 and SGLT2, which is the sodium glucose cotransporter, and it is located in the kidney. That's number now I don't know why they did this, but it should be like this. I mean, the small intestine has 1 and the kidney has 2. If you forgot about it, you have 1 small intestine, you have 2 kidneys. Okay? So brains prefer glucose but may use ketones body during starvation. So RBCs utilizes glucose as they lack mitochondria for aerobic metabolism. Yeah, so the RBCs themselves, they don't have a nucleus. They don't have a mitochondria. So the RBCs, for them, it's impossible to do oxidative phosphorylation. Thus, they must do what? They must use glycolysis. So, black lips. Insulin-independent glucose uptake can happen in the brain, RBCs, intestine, cornea, kidney, liver, beta cells, placenta, and spermatozoa. Why? Because they do use other forms of gluts. As I said, the spermatozoa, let me tell you, the beta cell of the pancreas, the brain, and the RBCs are high yield to know. Oh, and the SGLT1 and 2 are high yield to know where are they located, which type of glut they have. Okay, so the next one is the regulation. Glucose is the major regulator for insulin release. Increased insulin response with oral versus IV glucose is due to incretin. We studied about this, guys. It was the GLB. Remember when I told you, if someone takes like an IV glucose and then you check his insulin level, and somebody takes orally glucose and then you check his insulin level, which one of the two will have higher insulin level? The one who took it orally or the one who took it IV? the glucose. Orally, obviously. Why? Because when you take the glucose orally, that will stimulate something called glucagon-like peptide, GLP, also known as incretin. And that is going to stimulate your pancreas to secrete more insulin. So glucose-dependent insulinotropic polypeptide, the GIP, will be released, which are released after a meal and increase the beta cell sensitivity to glucose. So the release can be decreased with a few things. For example, the alpha-2 and the beta-2. Okay, so alpha-2 activation can decrease it while beta-2 activation can increase it. How do I memorize that? I just memorize the mnemonic KISS. Okay, KISS. So alpha-1, alpha-2, beta-1, beta-2. Since on the islet cell we have, they said alpha-2 and beta-2, the alpha-2 is inhibitory, yes? The beta-2 is stimulatory. So this one is going to increase the insulin release, and this one is going to decrease the insulin release. The next thing is that glucose enters the beta cells, which is going to lead to glycolysis. Glycolysis increases your ATP, which will help you to make basically plenty of ATP, which is going to do the following: block the channel. So increase ATP generated from glucose metabolism. It closes the potassium channel, which is actually the target of a drug called sulfonylurea. You remember I told you about people who take sulfonylurea, and it's written that the C-peptide in patients with sulfonylurea will also be high. Why? Because sulfonylurea work at the physiological pathway of the insulin release, which also can lead to increase of both insulin and the C-peptide. So after the blockage of the potassium channel, we will have depolarization of the cell. How come? Well, the potassium has a positive charge, and when it increases inside of the cell, this is going to lead to depolarization. Eventually, the voltage-gated calcium channel will be opened, and some calcium will be going in, increasing the intracellular calcium level. So they write, closes potassium channels, target of sulfonylurea, and depolarizes the beta cell membrane. Voltage-gated calcium channels opens, and we will have a calcium influx and the stimulation of insulin exocytosis from the vesicle into the circulation. And that's it. That's how insulin is produced and released. I know that it's kind of tricky to memorize these ones. Yep, the glutes tend to be a little bit painful to memorize. So the next thing is adrenal steroid and congenital adrenal hyperplasia. Each and every one of you will get at least one question about this. So if we speak about adrenal hyperplasia and adrenal steroids, first of all, you need to know where they are produced, with the help of what they are produced, and what do they do when they are produced. Okay? So, and which deficiency will lead to what? So let's start with the following. If we speak about the adrenal gland, it has a cortex, it has a medulla. The cortex has a 3-layer known as GFR: glomerulosa, fasciculata, and reticularis. GFR. So here you can see the zona glomerulosa, fasciculata, and reticularis. Correct? So this is one zone, two zones, three zones. Three zones we have. Okay, so why do we call it glomerulosa glomerulosa? Why do we call the fasciculata fasciculata? Why do we call reticularis reticularis? The glomerulosa in histology, I'll just show you an adrenal histology really quick. It has a glomeruli-like structure in the glomerulosa layer. So, yep. Okay, so you can see in the uppermost portion, this structure, they saw it and they were like, oh, it looks like a glomerulus somehow. And they decided to call it the glomerulosa structure. The area in between, they call it the fasciculata. And why it's called the fasciculata? Because it looks like ropes. Okay, guys? It looks like ropes. Fascicle in Latin means a rope. Reticularis. Why they call it reticularis? Well, reticularis in Latin means a net-like structure. Okay, so we have glomerulosa, reticularis, fasciculata, and reticularis. So what do they secrete? The deeper you get, the sweeter it gets. What does that mean? Well, you have here glomerulosa. Actually, this is much better picture. Glomerulosa, glomeruli-like structure. Fasciculata, in which you have this fascicle, a rope-like structure. And finally, reticularis, in which you have a net-like structure. If we speak about what do they secrete, that's our job today. First of all, they make mineralocorticosteroid, glycocorticosteroid, and sex hormone, respectively. Can someone tell me, please, all of these hormones I just mentioned, are they peptide, steroid, or what are they? They are a steroid type of hormone. So it's important. The steroid hormones are all made out of what? What is the substrate? What do they make them out from? A lot of people say fat. This is not correct answer. Cholesterol. Excellent. Good. So, yep. So we have ACTH. ACTH is a hormone produced by the anterior pituitary gland. Remember, it comes from something called the obeomelanocortin. That's why people with ACTH, when it's high, these exact people also are going to have a high MSH. So when they are going to have high MSH, which is the melanin stimulating hormone, they also get something called hyperpigmentation. Yes? So they're right. Okay, so let's go with this pathway, see general stuff, and every time people see that, they get like anxiety. You should not. There is not much actually you need to know here. So first thing to know is ACTH controlled this process by controlling a hormone called cholesterol dismolase. This cholesterol dismolase basically initiate the procedure by converting cholesterol into something you don't need to know. It's called the pregnenolone. But basically the cholesterol dismolase is using cholesterol to make it. Okay, what do we make? Well, you make aldosterone, cortisol that is going to be converted into cortisone, and finally the sex hormones. Let's start with this area. So the aldosterone, what is the function of the aldosterone? Does anybody remember? Okay, it increases the blood pressure, increased reabsorption of sodium, that increases the blood pressure. And what about the potassium? Increased potassium excretion. An idea about the pH? Excellent. Yes, pH will be up. Absolutely. Remember, potassium gets out, so hydrogen gets out, so you get basically metabolic alkalosis. Okay? Yep. So you take a look here and you can see the aldosterone, you know its function, and that's the important thing. Remember, a high amount of angiotensin 2, which is a product of the RAS system, can inhibit the aldosterone by decreasing the aldosterone synthetase activity. And also, you need to know that some hormones help us propagate in this system. Most of them you don't have to know, you only need to know 3 of them. The first one is 21 hydroxylase, 11 beta hydroxylase, 17 alpha hydroxylase. The other one, irrelevant. They don't ask about them. So, if I get a 21 hydroxylase deficiency, which substances are going to increase? The answer is 17 hydroxy progesterone. Well, someone will be like, what about the progesterone? Progesterone seems to be correct. Yeah, but tell me, guys, when you have a defect of this guy, do you have a defect of this guy? No. So can you convert the accumulated progesterone into 17 hydroxyprogesterone? So mainly, which one is going to be elevated in case of deficiency? Absolutely, the 17 hydroxyprogesterone. And that's what they not the progesterone. Why it's not the progesterone? Because we inhibited this guy. It's true, this will be increased, this will be increased, but this pathway is working. Yeah, if this pathway is working, this will be increased much more than this guy. Yes, it just like it gets converted, and thus this one is going to be much higher than this one. So in case of 21 hydroxylation, which control this step and this step, we will have much higher 17 hydroxyprogesterone than progesterone. Okay, so well, but I see we have increase of hydroxyprogesterone. What is the big deal? Well, there is a big deal, because in case of this 21 hydroxylation defect, you will have plenty of hydroxyprogesterone, which will be converted into sex hormones. Yeah, so sex hormones like androstenedione and testosterone, and also dihydrotestosterone. Well, there is the problem. In men, it's no problemo. But if it happens in a lady, it's going to lead to absolutely correct virilism. What is the difference between virilism and hirsutism? Well, hirsutism, it's when the lady has a lot of hair, okay? But if we speak about virilism, it's an actual change in the external genitalia of the lady, okay? That's virilism. So yeah, this can occur in case of a 21 hydroxylase deficiency. Okay, guys, there is a trick they mention here. I always use it. It always works. It's really interesting. They tell us that if the enzyme defect starts with 1, the patient is going to have high blood pressure. But if it ends with 1, the patient is going to have virilism. So if I'm speaking about 11 hydroxylase, they are going to have hypertension and virilism. If I'm speaking about the 21, they are only going to have virilism. If I'm going to speak about the 17, what do you think? 17 will be blood pressure, because only the first one. Yep. Excellent. Okay, let me re-say it. Yeah, okay. If the enzyme, if the deficit enzyme starts with 1, it will lead to hypertension. So 17, does it start with 1? The answer is yes. 17 hydroxylase deficiency will lead to hypertension. Yeah? Well, what about 11? Yes, it will lead to hypertension. Well, what about 21? Any hypertension? Virilism. Absolutely, because they say if the deficit enzyme ends with 1, it will lead to virilism in females. So except 21, what else can lead to virilism? Except 21, it will be 11, obviously. Yep. Okay. So, so from now on, anytime you see, 21 deficiency, okay, so that is going to lead to virilism. It ends with 1. 11, both hypertension and virilism. 17, only hypertension. Okay, so we spoke why the 21 hydroxylation lead to virilism. Basically because you have led to a halt in the pathway going down, and now the whole thing is going this way. Yeah? So the next thing we are going to speak about is the 11 beta hydroxylation. So when there is a defect in this one, this patient, aldosterone like mutable, I don't get it. Okay, the one who said that, please explain, because I don't get it. So if we speak about one by one, let's start with the 21 hydroxylase. these patients are going to have a defect in this one. So obviously the mineralocorticosteroid are down. The potassium, if you have low amount of aldosterone, what was the function of aldosterone? Excrete potassium. So now it's deficit. What you will have? Logically, high potassium. Yeah. So the blood pressure, no mineralocorticosteroid, the blood pressure goes down. And also, it does not begin with one. What about cortisol? Well, we have blocked the whole thing here, so it will be down. What about sex hormone? Well, we have shifted everything to the right. Yes? So the 6 hormones are going to be up. Okay. So in the laboratory, you are going to see increased activity of the renin. Why? Because the aldosterone is low. Yeah? And also, this is important, 17 hydroxy progesterone. So this is actually factoid. You must memorize this. A 21 hydroxylation defect is going to increase the 17 hydroxy progesterone. If you forget about this, just, I don't know. For me, I used to imagine like 21 and 17. If you flip the numbers, it becomes something like this. Yeah? So I don't know. Just like 21. If you flip it, it becomes like 1 and 2, and I imagine the 2 as 7, and it works for me, but I don't think it will work for you. So yeah, you need to find some association between these two. So 17 hydroxyprogesterone, it's going to be increased. It's most common and it presents in infancy with salt wasting. Why? Because no mineralocorticosteroid, so no salt in the body. Yeah, they cannot retain sodium anymore. Or childhood precocious puberty. Why they get the precocious puberty? Too much sex hormones inside of the circulation because of the shift to the right. Okay, so in the ladies they will have virilism. Let's speak about the next disease, which is the 17 alpha hydroxylase. The 17 alpha hydroxylase deficiency, boom, this one is messed up. Yeah? Well, if this one is messed up, look what happens. You cannot convert this to this, but the downward conversion is okay. That means you cannot make the cortisol anymore. Yeah? You cannot make the cortisol anymore. But can you make the aldosterone though? Yep. So the aldosterone is going to be high, which is also known as mineralocorticosteroid. The potassium level is going to go down. Blood pressure obviously is going up because of the mineralocorticosteroid. There is no shift to the right, so the cortisol will be low. The sex hormone will be low. And the labs will show a decrease in androstenedione. Why there is a decrease in the androstenedione? Because this right shift, the whole thing is defected. So this one is defected, and this one is defected. Okay, so for ladies, first of all, for men without testosterone, can they have normal formation of the penis and external genitalia? Oh my God, somebody wrote the answer before I even finished the question. Yes, they will not. Okay, so they also can have undescended testes. Guys, if somebody has an undescended testes, is it a problem or it's okay? Is it just cosmetic problem? Or it has some serious, yes, it can lead to cancer, absolutely. So if you, if the patient has this testicle stuck there, how long can you wait for it to descend? And then you will be like, okay, that's it, surgery. Okay, so mostly it descends until 1 year, but we wait only for 6 months, okay? We wait only for 6 months. You will not wait for 1 year. Okay? So you wait for 6 months. After that, you need to do surgical intervention. Get it down there. Okay? So let's say that you did not do the surgical intervention and the patient comes, he's 15 years old. Will you take the testicles, the undescended testicles, down to the scrotum, or you will take it out of his body? Out of his body or out of the testicle? Out of scrotum, sorry. Out of the body. You must take it out of the body, because regardless of the fact that he does not have cancer now. Even if you put it back in his scrotum, he will have the cancer. Okay, he's now high risk for cancer. Just take it out. Okay, guys, if you palpate a mass inside of the patient testicle and it's painless and it's big and you put a light on it, it does not transluminate, you highly suspect cancer. Yes, you highly suspect cancer. What you should do: 1, biopsy; 2, remove the cancer. Like cut the whole thing. Biopsy, or yeah, only 2 options. Choose. Yeah, you need to remove the whole thing, because if you do a biopsy, you will have, in testicular cancer, you have high risk of dissemination, in which you will have like the cancer all over the place. Okay, so let's take a look at the next thing. So the next thing is like an XX, ladies will have lack of secondary sexual development. By the way, guys, which hormone controls libido? Is it testosterone? Well, I mean in a lady, not in a man. Libido in a lady, is it controlled by estrogen, progesterone, or testosterone? In a lady, the libido is controlled by testosterone as well. Okay? So in men and ladies, it's testosterone. Okay, you know what is libido? The sexual desire, basically. 11 beta hydroxylase. 11 beta hydroxylase deficiency will lead to basically both high blood pressure and ambiguous genitalia. Let's take a look at it. Okay, so this is messed up. Yeah? If this one is messed up, let's see what happens. They write decrease in the aldosterone, but the precursor, which is the 11-deoxycorticosterone, will be high. Yeah? And this guy works exactly like aldosterone. A little bit weaker maybe, but still, it works like him. Which still can lead to high blood pressure. The potassium will drop, high blood pressure, obviously, because the this precursor will be acting like an actual aldosterone. So it will lead to the exact same symptoms as aldosterone, but with a low aldosterone level. The 6 hormones and the cortisol, so the cortisol, obviously, it will be low, yeah, because this is defected. And the 6 hormones, we are shifting to this side now. So the 6 hormones are actually going to be elevated. So the renin in this patient is going to be low. Why? Because after all, we have a high blood pressure because of the precursor. And it presents in infancy with severe hypertension, or in childhood. Why? Because of the precursor. And precocious puberty. Why? Because of the 6 hormone. And in ladies, it can have virilism. Good. Nice. All of these diseases are autosomal recessive disease. All of these diseases can have hyperpigmentation. How come? Because if you have decrease of any of the products, what hormone will be increased? ACTH, which is co-produced with MSH. Okay? And that leads to the hyperpigmentation. Okay, good. So I know that you might think that there is other stuff here, and there is. But each of these is a whole topic that will be discussed later. For example, I cannot speak with you about the aromatase inhibitor if we did not speak about reproductive. It will not make sense. But yeah, in general, this pathway, it's one of these pages we keep coming back to, and we always keep learning from it. Okay? So here we have finasteride. It's going to inhibit the 5-alpha reductase for some function. We are going to speak about the zoles, and they are going to inhibit the aromatase for some function. So yeah, just wait for it. Finasteride can be used for PBH. Nice. Okay. Benign prostatic hyperplasia, which is a topic we'll speak about later. Don't stress yourself too much about it. Speaking of stress, let's speak about cortisol. So cortisol is produced by the which area? GFR. F. Fasciculata. So, guys, what do you think? Do you have more cortisol early in the morning or in the afternoon? So the cortisol, it's actually more in the morning, early morning, to help you to get up from the sleep. Some people have it low all the time, which is, yeah, these are special people. But in general, cortisol must be much higher in the morning to allow you to start your day. So it increases your appetite, increases your blood pressure as well. How? By upregulating the alpha 1 receptor at the arterioles, and that will lead to vasoconstriction. Okay? So increased sensitivity to norepinephrine and epinephrine. This is a permissive function. I will actually have to explain for you how it does it. It's a little bit of biochem basically. Just a second. Yep. If you see the norepinephrine can be converted to epinephrine using this long name enzyme that you don't have to know, but it's stimulated by cortisol. Okay? So, oops. Okay. So the next thing is about, they write for us here. So, yeah, at high concentration, it can bind to the mineralocorticosteroid receptor. And by binding to the mineralocorticosteroid receptor, it can lead to mineralocorticosteroid receptor like function. I like the one like stress to get up, which is actually quite true. Without like this stress, it's really, these people who have really high difficulty waking up from sleep in the morning, and like they must wake up at 6 o'clock in the morning, but they stay in bed until 9 o'clock in the morning. Do you know it's a sign of what? No, it's not sign of lack of cortisol. This is psychiatry. This is a sign of a typical depression, especially on the USMLE. Please know it. Yep. So, yeah, basically when the patient becomes at a place that he is feels he cannot do anything, he just try to shut everything down, So that's a typical depression. Basically, it's really common for the USMLE. A typical depression, a person who eats a lot, a person who does not eat at all, a person who does not sleep at all or oversleep. All of these are signs of a typical depression. Okay, so also cortisol increases the insulin resistance, so it can lead to diabetes. And also keep in mind, anytime you give your patient cortisol, he will become hyperglycemic. Okay, so also these patients are going to have more gluconeogenesis, which means more glucose, more lipolysis, more proteolysis, and less glucose utilization. All of these factors will lead to increased amount of glucose. Yep. So, yeah, they can lead to obesity, but this is like Cushing type of syndrome. Okay, so they also decrease the fibroblastic activity, which lead to poor wound healing, decrease collagen synthesis, and something called the strea. So I want to show you strea. Oh yeah, can you see this strea? Yep. All of these. Okay, they are red. Some people will be like, no, it's like stretch mark. Yeah, well, stretch mark, when you look at the abdomen, some of them will be red, some of them will be white. They are variable, mostly white actually. But these ones are all red, okay? So, okay, good. The next thing, the cortisol lead to a decrease in the inflammatory and the immune response, which lead to inhibition of a production of leukotrienes and the prostaglandins. How come? Well, there is a pathway called, let me show it to you. That's the trick. That's the trick. It's not the interleukin 2 and FKB pathway. It's a different pathway. Okay? So there is something called linoleic acid. Okay? Cortisol can function in two pathways, not one. So there is something called the linoleic acid, which gets converted into something called arachidonic acid. The process of conversion is called, is mediated by phospholipase A2. Phospholipase A2. So we have arachidonic acid. Arachidonic acid can be converted into leukotrienes with the help of 5-lipoxygenase. And arachidonic acid also can be converted into prostaglandins with the help of cyclooxygenase. Okay, so where does cortisol work? Actually, cortisol work at this guy. Okay. Oh, I did something bad with the pen. Just a second. Yes. So yeah, this guy. So inhibit no, it does not inhibit the cyclooxygenase. It inhibits the phospholipase A2. Okay. So by inhibiting the phospholipase A2, you are going to get less prostaglandins, less leukotrienes. Okay, everything is going to go down. Where does the linoleic acid come from? It comes from the cell membrane. Okay, of what? Macrophages. Nice. So let's see what they write here. Also, they can lead to so they write anti-inflammatory by decreasing the production of leukotriene and the prostaglandins, inhibit white blood cell adhesion. Okay, so you will have more cells circulating because they cannot adhere. So you will get increased amount of neutrophil. Also, they can block the histamine release from the mast cells and lead to eosinopenia and lymphopenia, and block the interleukin 2 production, which decreases the activation of the lymphocyte. Okay, so also less bone formation by decreasing the osteoblastic activity. So this is why patients on cortisol are at high risk of what? A lot of things, but tell me one of them. Fractures, yes. What else? Moon phase, yeah. Also, they can have obesity because of the hyperglycemia, diabetes. They can have multiple infections. Yeah. So exogenous, wow, obesity, infection, yeah, all of these. So exogenous corticosteroid can cause reactivation of TB and candidiasis by blocking the interleukin 2 production. So let's try to understand this. So the steroid can block the interleukin 2 production, which means no lymphocyte. No lymphocyte can lead to dissemination of the TB and candidiasis. Okay. So the next thing here we have like the hypothalamus. It's activated by the stress or the circadian cycle, which can lead to corticotropin releasing hormone production. So the corticotropin releasing hormone can work at the anterior pituitary, which can eventually lead to more secretion of these three. That all come from pro-opiomelanocortin, so more ACTH, more MSH, more endorphins. What is endorphins? Opioid. Some people write, no, it's opioid. It's what numbs your pain. So ACTH will lead to release of cortisol from the fasciculata of the adrenal. Okay, and cortisol will lead to its function. Guys, since cortisol is a steroid hormone, will it function inside of the cell or on the surface of the cell? No, inside of the cell. Inside of the cell. Okay, all of the steroid hormones function inside of the cell. Make a note about this. All thyroxine, T3, T4 function inside of the cell. Also, write a note. Vitamin D3 function inside of the cell. So regulation. CRH from the hypothalamus stimulate the ACTH can enter lipid soluble and membrane is from. Yes, absolutely. So regulation, CRH stimulate the ACTH release from the pituitary. We will have cortisol production in the adrenal from the zona fasciculata. We can have an excess cortisol will lead to reduction of the CRH and reduction of the ACTH and cortisol secretion if you give it from the outside, for example. Chronic stress may induce a prolonged cortisol secretion, cortisol resistance, impaired immunocompetency, and dysregulation of the hypothalamic pituitary adrenal axis. Basically, chronic stress, like medical students, are more likely to get infections. Medical students are more likely to get the anxiety. We know why, but they are also more likely to get infectious disease because their immune system is much more inhibited. Okay. Appetite regulation. I'm going to speak about ghrelin, leptin, and endocannabinoid. So ghrelin. Do you remember where was ghrelin produced? We spoke about it. No, it was not the pituitary. Ghrelin. It was not the adipose. Excellent, it's the stomach. So let me describe for you how the production occur. Well, it's produced from the stomach. This is actually one of the reasons why a sleeve gastrectomy works, because during a sleeve gastrectomy, we do reduce the amount of the stomach, but you also remove the ghrelin secreting cells, as you can see here. So removing the ghrelin secreting cells is going to lead to less amount of appetite. Yeah? Yep. So they're right. They somebody wrote vacuous. I'm not sure what that means. So ghrelin stimulates hunger. Orexigenic effect. Guys, if you see delicious food, you start becoming hungry. And if you become hungry, it's a problem. So, and which nerve supply the stomach? Yes, it will be the vagus nerve. But if you mean it's related to the stimulation of hunger, the answer is yes. Actually, it does, because it's connected to our brain, and it's basically an orexigenic effect. Okay, and we are going to have production of a few things. First of all, the ghrelin release happens via ghrelin secretagogue receptor. Guys, anytime in medicine you see this thing, AGOG, it means like, it looks like it. It mimics it, okay? It's produced by the stomach. So sleep deprivation, fasting will lead to its, obviously, increase. Or Prader-Willi, yeah? All of these can increase the ghrelin production. So let's take a look at a patient with a humongous amount of ghrelin, a Prader-Willi patient. Prader-Willi. It's a microdeletion at the chromosome 15. These patients will be quite obese and they will not live for long. Okay? So, the next thing, ghrelin makes you grow hungry. It acts at the lateral areas of the thalamus, which is the hunger center, which increases the appetite. And we will learn about this more during neurology. Okay? So, leptin. Where is leptin made at? Well, somebody said adipose. Adipose is correct. Okay. So it's actually made in the adipose. In the stomach we have ghrelin, and in the adipose we have the leptin. So leptin comes from the word libo, okay? So what does libo mean? Libo means fat. Okay, what does adipo mean? Adipo mean fat, okay? Adipo and lipo, both of them mean fat. So it's the satiety hormone. After you ate, you feel full, you don't wanna. Yes, it's Latin and Greek, absolutely. So satiety hormone. So after you ate, you don't want to eat anymore. So you feel this satiety feeling, which is happening because of the leptin, which is produced by the adipose tissue. So a mutation of the leptin gene can lead to severe obesity. Well, guys, is obesity autosomal recessive, autosomal dominant, X-linked recessive, X-linked dominant, or polygenic? Polygenic. What is another way we can say polygenic? Multifactorial. Yes, multifactorial. So multifactorial basically is the exact same thing as polygenic, and these patients is like they do have the, how do you call it, the genetic predisposition for it, you know, but they don't have, and they also have the environmental cause. Okay, so yeah, hereditary plus environmental cause. So they're right. Oh, by the way, there is a USMLE question that always tell you, a patient comes to you and he's like, oh, you tell him about that his BMI is 45, and he tells you, no, 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 all of my family is fat, so it's okay. What should be your response for him? And he asks you to, well, justify it for him. So he tells you, all of my family is fat, and isn't it right, doctor, that basically like obesity is hereditary and it's not my fault, doctor? What you should tell him? Well, he's asking you, you cannot ask him back. Yeah, so no pain, no gain. I like it. Okay, no, actually, you need to tell him, well, it's true that, look for this answer. Don't be an ass to the patient. Remember, because if you be like an ass to the patient, that you are going to get the question wrong. So be like, it's true that obesity has some hereditary association, but also modification of the diet and exercise can help relieve the symptoms. You always need the most open-ended type of answer that does not harm anybody. Okay? So, oh, by the way, there's only one case that you can be like a total ass with the patient, in which if he asks for a treatment that does not exist. Okay? For example, if the lady has a placenta previa, I hope you know what that is. It's like when the uterus is like this, and this is the opening of the uterus, and the placenta is right here. Yeah? And the baby is here. Can she deliver the baby vaginally? Absolutely not. You will not allow her to do that. So it's closed. If she tries to deliver the baby vaginally, what will happen? Well, the baby will be dead, that's true, but she will be dead as well. Okay? The hemorrhage will be so severe, both of them will die. So, if such woman comes to you and be like, well, doctor, I will only give vaginal delivery. Can you do it for me? What your answer should be? You need to be dead serious with her. You need to be like, listen, vaginal delivery will kill you and will kill the patient. So there is no point of doing it, okay? So it's the only case that you are allowed to be a total, yes, absolutely. You need to tell her no. You tell her the complication, and basically we are doctors, we don't kill our patient. So if the patient is telling you, kill me, you will not do it. The same with performing a procedure that has 100% chance of killing the patient. Okay? Okay, by the way, are you allowed to practice euthanasia? Euthanasia is killing the patient. If the government allows it. What about if the government allows it? Absolutely, do no harm. So you are not allowed to do it, even if the government allows it. We are not allowed to do execution. You are not allowed to kill the patient. You are not allowed to participate in torture. You need to respect these privileges that medicine gives to you. Okay? Okay. So the next one. Um, the next one goes like this. Obese people have increased leptin due to increased adipose tissue, but are tolerant to resistant to leptin anorexic effect. What is anorexia? I don't wanna eat. Leptin makes your satiety goes down. Sleep deprivation and starvation decreases leptin production and increase ghrelin because they force you to go to eat. So leptin keeps you thin. And it acts on the ventromedial side of the brain and ventromedial. And if you destroy it, what will happen to the patient? So that decreases the appetite. What happens if you destroy the ventromedial area of the brain? Can leptin act on it? The answer is not. So the patient is going to eat all the time. What happens if you eat all the time? Very massive. You become very massive. Okay? Ventromedial, very massive. Okay? So destruction of the ventromedial make you very massive. Destruction of the lateral makes you lean. Okay? So endocannabinoid type of hormone. So these guys acts on the receptor which is located in the hypothalamus and the nucleus accumbens. I don't know, guys, if you do drugs or not, but if you ever seen anybody who do cannabis, what do they do after they do cannabis? They come and steal your fridge. Absolutely. They like ice cream. Okay. Mushy, munchins, absolutely. Yep. They will be really hungry. I like the fact that it's the only question I ask and everybody answers directly. It's like a lot of experience. So, okay, so it's going to act at the nucleus accumbens and the hypothalamus. Two key brain areas for the homeostatic and hedonic control of food intake, which means how much should I eat? How often should I eat? All of these areas are messed up and the patient start eating like crazy. So they have much more increased appetite. Exogenous cannabinoid can cause the munches, which is like they come and eat your food. People who like to eat a lot. Okay, by the way, do we use cannabinoid to stimulate people to eat? Yes, we do, especially in HIV patient at the end stage and cancer patient. Okay, so cancer patient and HIV patient in the end stage, they have zero appetite. They are going to die, but you need to keep, helping them. Okay, guys. So let's take 10 minutes break. Come back, finish up physiology, and we will see what we'll do after that. So see you guys in. Hello, everyone. Welcome back. So let's do the last thing in this chapter. I mean, in the physiology chapter, is the signaling pathway of the endocrine hormones. Guys, these things are difficult. Because they are difficult, there is a couple of pictures that will help us to memorize them. I will show you them in a moment. So actually, let me first of all make you understand what we are speaking about. When we are speaking regarding the pathways, the secondary pathways, and the signaling pathways, when we have a cell, how does this cell knows that this hormone wants this or that? Well, a hormone binds to an exact receptor. This receptor, well, not all of them, but some of them binds to a receptor. After binding to the receptor, there will be an inner function that is going to happen, and that will lead to a response. This is oversimplification of the process, but in general, it is what it is. It is what you need to know in general. So, cyclic AMP function, also known as the CAMP, we keep saying like CAMP, cyclic AMP. It has all of these hormones. You are like, how the hell I'm going to memorize all of these hormones? You don't have to memorize them. Actually, I'm just going to find it out for you. Secondary messengers, Reddit. Just a moment. So basically, to be able to memorize all of them, there is like one picture that have all of them in it, and I hope I can find it. No, not this one. Just a moment, please. Yes, this one. Okay, nice. So it's just like one picture that has all of them in it. Like if you memorize this one picture, you will, and you eventually you will have to memorize it. Whatever you do, you will have to memorize it. So you can see the here the bath. Yeah, there is a bath here. So that's parathyroid hormone is mediated by cyclic AMP. Can you see the camp here? And there is a pregnant lady, so HCG is cyclic AMP. The marshmallow, it's cyclic AMP. The fire, FSH, is cyclic AMP. TSH, the torch, cyclic AMP. Glucagon, which is actually quite important, they do ask this, it's cyclic AMP. Okay, good. So this is the first picture I want you to master. And there is one more. I hope I can find it here. The other one is for the IB3, okay? So yes, good. So IB3 or iPhone 3, okay? It's the IB3 pathway, or also known, IB3 is also known as the GQ pathway, okay? So let's take a look. So cyclic AMP, all of these guys, marshmallow, bath, yeah, so torch, the fire. So I hope that helps the picture. And the other ones is called cyclic GMP, which is our like the ones produced from the heart, for example, like the brain natriuretic peptide, atrial natriuretic peptide, which and epithelial derived growth factor, which are all responsible for vasodilation. So everything responsible to vasodilation, this is cyclic GMP. The IB3, it's the other picture I just sent, so you can take a look here. The IB3, the iPhone 3 store, you can see the gas for gastrin, yeah? And you can see the GnRH, this guy, which is the groundhog. And you also can see the OX for oxytocin, yes? So yeah, this is actually really a helpful picture. If you memorize everything in it, you are able to get any question correct on it. Intracellular receptor, as I told you, it's the sex hormone, the steroid hormone, the cortisol, the testosterone, the estrogen, the progesterone, the aldosterone, the T3, T4, and the vitamin D. Yep, all of these are intracellular type of receptor. Tyrosine receptor tyrosine kinase, we have the insulin and the growth factors. Actually, insulin is considered as a growth factor because after all, what does it do to the protein synthesis? Does insulin increase or decrease the the protein synthesis? It increases the protein synthesis. Okay, so the MAP kinase pathway is the pathway that is for the secondary messenger in this guy. So also we have the serine Theorion kinase receptor. This is a new. It was not in the book before, but it mediates the TGF beta. Anybody remember what is the function of TGF beta? Fibrosis, that is correct. Okay, so non-receptor tyrosine kinase, like the granulocyte, colony stimulating factor, erythropoietin, thrombopoietin, prolactin, and immunomodulator, like the cytokines, interleukin 2, interleukin 6, interferons as well, and the growth hormone. All of these are mediated by something called the JAK-STAT. Guys, a patient who has polycythemia also had a JAK-STAT mutation, which led to overactivation of the erythropoietin receptor, which led to polycythemia. Okay, so the JAK-STAT is responsible for all of the non-receptor tyrosine kinases. Okay, so the signaling pathway. Okay, so how does a steroid um, lead to activation of a cell? Does it work intra or extracellularly? Intracellularly, absolutely. Okay, so they write here binding to a receptor located in the nucleus or in the cytoplasm. Okay, so after the binding uh, happens, either the receptor was located here or even here. The receptor is going, we will have this dislocation basically. So they write the transformation of receptor to expose the DNA binding protein, which is going to eventually bind to the protein. We are speaking about now, actually, this is not cellular, this is intracellular, because the receptor here is either located in the cytoplasm or inside of the nucleus. The extracellular receptor should be located at the cytosol, I mean the outer membrane, okay? The outer cytosol. So here we have the hormone binding to its receptor, which is located in the cytoplasm, and they lead to like a transformation of the receptor to be able to bind the gene. So after they bind the gene, they lead to an enhancer-like element in the DNA, which eventually is going to make exons and introns. We remove the introns and we we put a cap, we put a tail, we have a mature mRNA, which eventually go to the ribosomes and make a protein, which is the response. So steroid hormones are lipophilic and therefore must circulate bound to a specific binding globulin, okay? Which increases their solubility. Yes, so the steroid hormone, they cannot circulate alone, because if they circulate alone, basically they will bind to any nearby object and they will be just stuck to it. Thus, they must have something to keep stuck on it all the time. So in males, increased sex hormones binding globulin lowers the free testosterone, which lead to gynecomastia. Let me explain this. So there is a protein called sex hormone binding globulin. Let's consider that this is the guy. If you have 3 testosterones, okay, and you have one sex hormone binding globulin, it only can fit one. So one will be bound and 2 will be free. Which one is active? Is it the free one or the bound one? Who is active? Absolutely, it's the free one. The free one is active. So the free one is active, and thus, if you have 2 sex hormone binding globulin, the other one is going to bind. So the more sex hormone binding globulin you are getting, the less free testosterone you are going to get. And because it's the functional one, it basically means lack of testosterone, which is going to lead to gynecomastia. In females, decrease in the sex hormone binding proteins rises the free testosterone, which eventually will lead to hirsutism. Okay? Increased estrogen can be after OCBs or pregnancy, which is going to, well, basically increase the amount of the sex hormone binding globulin. Okay, guys, so I will call it off for now. We finished all of the physiology of the endocrinology, which is really good. Tomorrow, we'll be starting with the pathology. The first couple of topics are really easy, actually. But when we go a little bit deeper, easy. Hopefully by tomorrow we'll be able to finish diabetes. That will be great. Or at least reach it. If we will be able to reach diabetes or finish it, that will be great. So for now, I will be sitting down and writing down the schedule for you guys, and I will be sending it right away. So see you guys tomorrow. Bye-bye.